that's the rotator cuff design, right? And if you feel pain there, you feel disturbance there, then you got to be suspicious that a rotator cuff is disturbed. The AC compression test. I'm going to come down here and find some part of the arm that's distressed, like that feels a little tight, like right there. I'm going to press down the clavicle, wait for a few seconds, and then ask, is that feeling good or down there? Feels a lot better. I can feel the whole thing softening up, right? And then I let go. And let's just see, there we go. It's really subtle, but there's the top is AC and there's the top is chromium. So there's a bump right there. And I can feel the bump disappear when I do the clavicle compression test. I'm going to keep the clavicle compressed for 10 to 15 seconds at least. All right? This has also been known to relieve hand tingling, numbness, stuff like that, right? And then I let go and it all comes right back. So the idea there's a trap in here, whatever, right? Next is the adjusting. I will hand you a spring loaded adjusting instrument, so you don't have to bring one. Okay? And to adjust the AC, you're going to press down on the clavicle, have your shoulder, have the patient lift up just a little bit, shrug the shoulder, and then tap. That's it. Okay? Then adjusting humerus, and I've got anterior inferior or posterior superior. So posterior superior is what I'm talking about. You come in, find the shoulder blade, move lateral to the shoulder blade. Come in on top of the humerus and go tap. Okay? If it's an anterior humerus, you're going to come up here and I hope to have a big cross arm across their chest and come in and come up underneath the humeral head and go pam. Superior to inferior superior line of right. Okay? Now you can do all that on a drop taper too, but we're going to be in here for the test. Then we have elbow evaluation. And so I'm going to have you turn sideways just a little bit here so I can use this elbow here so they can see a little better. I'm going to come down the arm, find the elbow, bend the elbow, contact the top of the ulna, and then extend the elbow. I want the ulna to tuck. If it doesn't tuck, I can still feel part of the ulna sticking out there. I can park my finger on it. That means the ulna's gone posterior. Now, then I'm going to move over to the radial head, and I'm looking for where the capitulum is and where the radial head is. And if I can find top of the radial head, I shouldn't be able to find the top of the radial head. So there's the top of the radial head right there. Because I can feel the inside capitulum posteriorly, which would mean radius has gone anterior. So I'm going to have to go through the belly of Holocaust and find, there it is right there. Right? Feel that? Right. That's the top of the radial head. So then the next thing is how would you adjust? No, arm draw test. I'm going to support his arm, so I don't want to pull on the shoulder when I do this. Move your wrist and hand around. Relax. Now I'm going to draw the ulna down towards his wrist. I just hold it clunked. Does that feel different? So his ulna is clunked. I think I told you that story about the baseball player who couldn't extend. And I did the ulna draw test on him and clunking him. He couldn't extend his wrist before, and suddenly he did a push up against the wall. Okay, so that's the ulna draw test. The next thing is the adjusting. Posterior ulna.
Pam.
Yep. Anterior radius, pam, right? Right. Then the next thing is the wrist inspection, which is I'm going to come here and I want to feel all the carpal bones moving. Right? And this is going to be done after I'm going to do the adjusting until I've done all this, right? The evaluation noise. This is not too bad. But a lot of times you feel this thing stuck, right? Or grinding. Clicking, right? And those are all things that are not good. So the adjusting is like going to just coming in here and do a distraction, tap, and the manual one is to do a contact and slide away process of both bones, do a separation and then a distraction. And you fill up after you've got the forearm bones in place, right? So then we have thoracic and lumbar evaluation. So that's just your typical stuff. You guys got what palpation one, right? So you're looking for your rotations, right? So there's a little spinous left rotation there. So take T12 as spinous left. So you can come in and go like that. And if you have a transverse process, spinous process is to the left, then posterior TP on the right. Does that make sense? Think component. So I'll be tapping there. Now, if you're doing it in the drop table, you can use both hands. So I'm going to contact the spinous process this way, the transverse process that way, and do a drop with both hands. Right? Segmental adjusting.
Can you do that again, the opposite side so you can stand?
Like this?
Yeah.
So, with a hand?
Everything.
So, let's just say you've got spinous right here. This is what it feels like spinous right. If I'm going to use the tapper for this, I'm going to tap the spinous go over to the transverse process, it would be posterior on the opposite side.
Mm-hmm.
Tap, tap. Now, if I'm using my drop table, I'm contacting the spinous process with one hand, right? And the TP with the other hand, right? Like that.
Thank you.
I never stand on the left side of the page, right? I'm always on the left side of the page. So then, where are we? Knee. Pillow and knee. Place there for your head. So I'm going to say, evaluate me. You can tell me what I'm looking for. I'm looking for where the condyles are and where the plateaus are. Okay, that's it. So in this case, we got the underside of the condyle showing there. It's almost the width of my thumb. That's pretty good there. And there's the top of that tibia. There's the top of the tibia. So we got a posterior, an anterior tibia with a lateral displacement. Right? So then I'm going to say we have anterior tibia. I'm going to give you a listing, and you're going to set it up. And in the case of anterior tibia, you're going to put the roll just at the knee, above the knee. So you can drop on the tibia, because it's going anterior. Does that make sense? If it's a posterior tibia, you're going to put the roll underneath the tibia and drop on the femur. If it's a lateral tibia, I'm going to have you put the roll underneath the knee and go from, that's one, lateral tibia. So coming back this way, okay? And then I might do rotation, which would be you an internal, external rotation, and because I've never found really medial rotation, one time skiing into it. You can internally rotate the knee and then drop into it. Okay? Those are all permutations that I will ask you about. I'll only ask for one. Each do, like either an anterior tibia, posterior rotation, whatever. Okay? You're not going to make it. I mean, as you see, it takes a long time to do, and I'm not going to give you the whole thing, right? So if I made you, everyone tested this, it would be more than 3 hours. Adjusting, so then you're going to have to adjust, and then we've got evaluation. Okay, fib tip squeeze test. So you can tell me what the fib tip squeeze test is, where I'm going to find something that's distressed, like the TFL there, and that softens up as I pull it, right? Or it's the foot thing, like we're doing foot thing, so pain peroneus, if this is real tight right here, that's peroneus, so you're having a pain right here, a little bit of pain right there. I'm going to pull the fib tip down, and I can feel this is softness right now. So right,
Squeezing the strap.
I'm squeezing and bringing down, because again, most of us are going to have the fibula, from pounding, the fibula is going to go up a bit. So for instance, that's a little sore like right there. Not too bad, but just a little bit. And then I pull that down, and it's gone. So I'm going to say that suggests that the whole fibula is going up a little bit. Again, if you look at the tibia in AP view, you've got the plateau with an angle, knee here, right? Fibula's under here. Pounding up is going to cause it to separate. The more it elevates or translates up, that angle of the tibia is going to cause this space here between the two bones to widen, and then again, all the muscles of the lower leg attached to every bone and the neurosis and or the neurosis ligament. So that's the fib tip squeeze test. Adjusting is you grab the fibula, bring it down, and drop. I won't have you do that. That's just adjusting something. I can't help myself. And then we have evaluating, which is good. Then foot evaluation. So I want to know where the calcaneus is. I want to know where the talus is. I want to know where the metatarsals are. Okay? That's what you're saying. Then you can show me the calcaneal draw test. You can stabilize the lower leg and pull the calcaneus forward relative to the leg. The talar draw test is basically the same thing. You're drawing the whole foot forward relatively. You've got to stabilize the leg for this one. Okay? The draw test. And then adjusting. You're going to show me you're going to set up like that to adjust the calcaneus, to adjust the talus. Like I said, mostly I got a bolster right here. I'm dropping on the lower leg to bring the foot forward, or if I have anterior talus, I'm going to put the leg off the end of the table and then drop on the foot. Metatarsals. Okay. All right. Any questions?